Welcome to CPT Coding Guidelines Review, Endovascular Revascularization of Lower Extremities. Achieving accurate and complete coding is the purpose of coding guidelines. However, you can't take advantage of the benefit of having guidelines if you don't know what direction they provide. Even if you don't know the specifics of a guideline, just being aware that guidance is available for a particular situation is valuable. This series is designed to help you become better acquainted with often unfamiliar CPT guidelines for coding of significant procedures, with the intent of making you aware that the guidance exists to ultimately improve coding proficiency and boost confidence in your ability to code these procedures. The guidelines are waiting, so let's get started. Knowing something about the objective of a procedure and/or how the procedure is performed always promotes understanding of the direction given in the guidelines. This installment of CPT Coding Guidelines Review covers the guidelines for coding endovascular revascularization procedures. So, before we dive into the guidelines themselves, let's take a quick look at what endovascular revascularization is. Endovascular revascularization is a minimally invasive method for treating narrowing or blockages in the arteries of the legs. Endovascular means within a vessel. These procedures are performed through a puncture in the artery through which catheters are threaded to reach the area that needs treatment. Transcatheter procedures involve less blood loss and faster recovery times. Revascularization is the use of procedures to improve the flow of blood to an area where flow has been limited by narrowing or blockage of vessels. 3 types of procedures are used to revascularize or improve blood flow to the legs. These include atherectomy, stent placement, and/or angioplasty. These procedures may be performed alone or in combination with one another. If you'd like more detailed information about leg revascularization or endovascular surgical procedures, the references shown here are a good option for an expanded overview of these procedures. Endovascular revascularization procedures performed to treat occlusive disease are reported with codes from the range of 37254 to 37299. These codes are built on progressive hierarchies where more intensive services are inclusive of services of lesser intensity. For example, atherectomy procedures are inclusive of angioplasties. When more than one service is provided for a single vessel, the code for the most intensive service, inclusive of all the services provided for that vessel, should be reported. Only one code from the family of endovascular revascularization codes should be reported for each lower extremity vessel treated. These codes report 3 types of revascularization therapies: transluminal angioplasty, atherectomy, and stent placement. The procedures may be performed alone or in combination with one another. For endovascular revascularization codes, this is the progressive hierarchy of intensity based on complexity of service. Note that balloon angioplasty is included in all procedures of higher intensity and is not separately reportable when performed with another service. For this hierarchy, the most intensive or complex service is an atherectomy with an accompanying stent insertion, either with or without balloon angioplasty. The next most intensive service is an atherectomy, performed alone or with balloon angioplasty. Next in complexity is stent insertion, performed alone or with balloon angioplasty. And the least intensive service is balloon angioplasty alone. Lower extremity endovascular revascularization procedures reported with codes 37254 to 37299 all include the work of percutaneous or open surgical exposure, accessing and selectively catheterizing the vessel, crossing the lesion, radiological supervision and interpretation directly related to the interventions performed, imaging performed to document completion of the intervention and completion of the procedure, embolic protection if used, closure of the arteriotomy by application of pressure and arterial closure device, or direct suture of the arterial puncture, and balloon angioplasty when performed. If extensive repair or replacement of an artery, such as is reported with codes 35226 or 35286, or mechanical thrombectomy or thrombolysis is required, these are separately reportable in addition to codes from the range of 37254 to 37299. Selection of endovascular revascularization codes includes identifying the code that reports the correct type of lesion. Lesions are classified as either straightforward or complex. A straightforward lesion is a stenosis, and a complex lesion is an occlusion. Codes 37254 to 37299 are divided into 4 vascular territories: iliac, femoral and popliteal, tibial and perineal, and inframalleolar. A vascular territory is a collection of anatomically related arteries considered together for coding purposes. Territories are further divided into vessels for which a primary intervention code may only be reported once. Note the reference to one or more arteries. This means that at times multiple arteries may be combined into what is considered a single vessel for the purpose of code selection. All 4 territories each have specific guidelines. The iliac vascular territory is divided into 3 vessels: the common iliac, internal iliac, and external iliac. To report angioplasty alone or stent placement with or without angioplasty in an initial vessel in the iliac territory, assign codes 37254 or 37258 for treatment of straightforward lesions, or 37256 or 37260 for treatment of complex lesions. Angioplasty alone or stent placement with or without angioplasty in additional vessels are reported with add-on codes. Codes 37255 or 37259 are assigned for treatment of straightforward lesions, and codes 37257 or 37261 are assigned when complex lesions are treated. Lesions that cross from one vessel in the iliac territory to another vessel in the iliac territory are reported with only a single treatment code for an initial vessel. You may notice that there are no codes referenced for atherectomy procedures in the iliac vascular territory. These procedures are reported with a code from Category 3, 0238T. There are several guidelines related to the assignment of add-on codes for the iliac vascular territory. Direction for these codes includes: add-on codes may only be reported for distinct lesions in different vessels, not for distinct lesions within the same vessel. If more than one distinct lesion is treated in a single vessel, only one code is assigned, because codes are reported per vessel, not per lesion. A maximum of 2 angioplasty and/or stent add-on codes may be reported in a unilateral iliac vascular territory, because there are 3 vessels that can be treated. This would look like 1 code for treatment in an initial vessel and 2 add-on codes for treatment of each additional vessel in the territory, for a total of 3 codes per unilateral iliac vascular territory. Add-on code 37262 intravascular lithotripsy may be reported a maximum of 3 times in a unilateral iliac vascular territory, because there are 3 vessels that can be treated. This code includes all imaging guidance and radiological supervision and interpretation needed to perform the intervention. The arterial segments in the femoral and popliteal vascular territory include the common femoral, profunda femoris, which is also called the deep femoral, the superficial femoral, and the popliteal. This territory is divided into 2 vessels: The common femoral and the profunda femoris are considered a single vessel, and the superficial femoral and the popliteal arteries are considered a single vessel. All intervention types, angioplasty alone, stent placement, atherectomy, or atherectomy with stent placement, all either with or without angioplasty, are reported based on intervention type and by whether the lesion treated was straightforward, codes 37263, 37267, 37271, and 37275, or complex, codes 37265, 37269, 37273, or 37277. Angioplasty alone, stent placement with or without angioplasty, and atherectomy or atherectomy with stent insertion with or without angioplasty in additional vessels are reported with add-on codes. Codes 37264, 37268, 37272, or 37276 are assigned for treatment of straightforward lesions, and codes 37266, 37270, 37274, or 37278 are assigned when complex lesions are treated. Lesions that cross from one vessel in the femoral and popliteal territory to another vessel in the same territory are reported with only a single treatment code for an initial vessel. Guidelines related to the assignment of add-on codes for the femoral and popliteal vascular territory include: an add-on code may only be reported for a distinct lesion in a different vessel, not for distinct lesions within the same vessel. If more than one distinct lesion is treated in a single vessel, only one code is assigned because codes are reported per vessel, not per lesion. A maximum of one angioplasty, stent, atherectomy, or atherectomy and stent add-on code may be reported in a unilateral femoral and popliteal vascular territory because there are only two recognized vessels for coding purposes: the vessel comprised of the common femoral and femoral profundus arteries, and the vessel comprised of the superficial femoral and popliteal arteries. This would look like one code for treatment in an initial vessel and one add-on code for treatment of an additional vessel in the same territory, for a total of two codes per unilateral femoral and popliteal vascular territory. Add-on code 37279, intravascular lithotripsy, may be reported a maximum of 2 times in a unilateral femoral and popliteal vascular territory because, for coding purposes, there are 2 vessels that can be treated. This code includes all imaging guidance and radiological supervision and interpretation needed to perform the intervention. The tibial and perineal territory is divided into 3 vessels. The anterior tibial, the posterior tibial, and the perineal arteries are each considered a single vessel. For coding purposes, the tibio-perineal trunk is considered part of the posterior tibial or perineal artery and not a separate vessel, unless it's the only vessel treated. All intervention types, angioplasty alone, stent placement, atherectomy, or atherectomy with stent placement, all either with or without angioplasty, are reported based on intervention type and by whether the lesion treated was straightforward, codes 37280, 37284, 37288, and 37292, or complex, codes 37282, 37286, 37290, or 37294. Angioplasty alone, stent placement with or without angioplasty, and atherectomy or atherectomy with stent insertion with or without angioplasty in additional vessels are reported with add-on codes. Codes 37281, 37285, 37289, or 37293 are assigned for treatment of straightforward lesions, and codes 37283, 37287, 37291, or 37295 are assigned when complex lesions are treated. Treatment of lesions that cross from one vessel in the tibial and peroneal territory to another vessel in the same territory is reported with only a single treatment code for an initial vessel. Guidelines related to the assignment of add-on codes for the tibial and peroneal vascular territory include: add-on codes may only be reported for a distinct lesion in a different vessel, not for distinct lesions within the same vessel. If more than one distinct lesion is treated in a single vessel, only one code is assigned, because codes are reported per vessel, not per lesion. A maximum of 2 angioplasty, stent, atherectomy, or atherectomy and stent add-on codes may be reported in a unilateral tibial and peroneal vascular territory, because there are 3 vessels recognized for coding purposes. This would look like one code for treatment in an initial vessel and 2 add-on codes for treatment of additional vessels in the same territory, for a total of 3 codes per unilateral tibial and peroneal vascular territory. There is not a code for intravascular lithotripsy in the tibial and peroneal vascular territory. The inframalleolar vascular territory includes 2 arteries, the dorsalis pedis and the plantar artery, each of which is considered a single vessel. For coding purposes, the pedal arch is considered part of the dorsalis pedis or plantar arteries and not a separate vessel, unless it's the only vessel treated. To report angioplasty alone in an initial vessel in the inframalleolar territory, assign codes 37296 for treatment of straightforward lesions or 37298 for treatment of complex lesions. Angioplasty alone in additional vessels in the same leg are reported with add-on codes. Codes 37297 is assigned for treatment of straightforward lesions, and 37299 is assigned when complex lesions are treated. Lesions that cross from one vessel in the inframalleolar territory to another vessel in the same territory are reported with only a single treatment code for an initial vessel. There are several guidelines related to the assignment of add-on codes for the inframalleolar vascular territory. Direction for these codes includes: add-on codes may only be reported for distinct lesions in different vessels, not for distinct lesions within the same vessel. If more than one distinct lesion is treated in a single vessel, only one code is assigned, because codes are reported per vessel, not per lesion. A maximum of 1 angioplasty add-on code may be reported in a unilateral inframalleolar vascular territory, because for coding purposes there are only 2 vessels that can be treated. This would look like one code for treatment in an initial vessel and one add-on code for treatment in an additional vessel in the territory, for a total of 2 codes per unilateral inframalleolar vascular territory. There is not a code for intravascular lithotripsy in the inframalleolar vascular territory. When treating multiple vessels within a territory, one primary lower extremity revascularization code is reported. Treatment of additional vessels is reported with the appropriate add-on code. For lesions extending across the margin of one vessel into another vessel in the same or an adjacent vascular territory that can be treated with a single therapy, report a single primary code for the more distal of the adjacent vessels. Do not code for treatment of the additional vessel and/or vascular territory. For example, a unilateral lesion extending from the common iliac artery into the external iliac artery, opened by a single angioplasty with stent placement to open the entire lesion, is coded as either 37258 for treatment of a straightforward lesion or 37260 for treatment of a complex lesion. Do not report revascularization of both the common and external iliac vessels. When treating discrete lesions, if discrete lesions are treated with a single therapy, the intervention should be reported with a single primary code. If discrete lesions in two territories are treated with two separate therapeutic maneuvers, both primary codes may be reported. For example, if a patient has a lesion in the common iliac vessel and a separate lesion in the mid-superficial femoral vessel, which are treated with separate balloons, the CPT codes for that session include 37254, revascularization, iliac vascular territory, angioplasty, straightforward initial vessel, and 37263, revascularization, femoral and popliteal vascular territory, angioplasty, straightforward initial vessel. When the same treatment of an initial vessel is performed in the same vascular territory of both legs in the same session, append modifier 50 to the initial vessel code to indicate a bilateral procedure. If the same treatment of an additional vessel is performed in the same vascular territory of both legs in the same session, report the add-on code for treatment of an additional vessel twice, and append modifier 59 to one code to indicate different legs were treated. When different treatments in either the same or different vascular territory or territories are performed in the same leg or each leg, append modifier 59. This last guideline essentially boils down to, if you are reporting different treatments, you need to use a modifier 59 to denote that distinct procedures were performed. The guidelines for lower extremity endovascular revascularization procedures include several instructions related to what can and cannot be reported separately as a diagnostic procedure. The guidelines state that procedures that do not result in successfully crossing a lesion and a successful endovascular revascularization procedure are considered diagnostic procedures, which are reported with catheterization and angiography codes. Intravascular ultrasound used during lower extremity endovascular revascularization is separately reportable. Do not report catheterization for diagnostic angiography performed through the same access when therapy codes are reported for the same session, but do report separately catheterization for diagnostic lower extremity angiograms if a different arterial puncture is necessary. Diagnostic lower extremity angiography is separately reportable in addition to interventional procedures only under certain circumstances. These include when no prior catheterization-based angiography study is available, a full diagnostic study is performed, and the decision to intervene is based on this study. Or a prior study is available, but as documented in the medical record, the patient's condition with respect to the clinical indicators has changed since the prior study, or there is an inadequate visualization of the anatomy and/or pathology, or there is a clinical change during the procedure that requires new evaluation outside the target area of intervention. Thanks for watching. Health Information Associates is committed to providing educational products that help coders to be their best. So be sure to check out the other presentations in the CPT Coding Guidelines Review series, as well as our full catalog of courses at hialearn.com.